you open in prayer for us, please?
Oh, really?
I'm assuming.
Father, we thank you for this evening. We thank you for yet another opportunity, O God, to expand our knowledge, O God, and to learn. I commit this class to you. I commit Dr. McDermott to you, God. I pray your blessings upon her life, that you will give her the wisdom and the strength she needs to continue to impart knowledge to your people, O God. I commit tonight's presentation to you, God. I ask for your guidance, your direction, your help. Lord, that you will give us clarity of thought, clarity of speech, oh God, that the words we speak will be well understood, God. The concepts we discuss will be well understood, God. I commit tonight's session into your hands, and I thank you for a productive and an enriching session. In the precious name of Jesus. Amen.
Amen.
All right.
Amen.
Ladies and gentlemen, good evening. Oh, I assume you're live, so I will make my beginning comments that tonight is actually the final lecture for this class or course. And may I say it has been a privilege for me to have been here, but I will do that. I guess I'll do much more and say much more when the class actually ends. Just to underscore and reminders that the first post is due tomorrow evening, 11:55 Jamaican time and 1:55 Guyanese, and later in, I guess, another hour later Nova Scotia time. People have been asking about the take-home exam. If there are concerns, please say them now or hold your place.
Okay.
Dr. Mac, I'll be back.
You'll be back. Any concerns? Well, the exam is, that's why it's comprehensive, that's why it's a take-home. You have no midterm, you had no final where you had to study. I don't believe, you need to practice on the cases. Just to say that the cases, I'm not going to penalize you because you don't know. As long as you can intelligently make an inference on the case and think about the case, then that's what I'm looking for. Okay, you can argue successfully for the case. And what I plan to probably do is give you a longer case that we can hash out what I'm expecting for the exam. How is that?
You mean this evening, Dr. Mac?
I will try my best, yes.
That sounds like a great idea.
So, Dr. Mac, excellent idea. The concern that Victor and I had was the time frame, and we're saying because of the Christmas holiday, if it is possible that we could turn in the exam early January.
You hear that now, and people are saying that it was too long.
No, Dr. Mac, it's not.
That the time frame was very long. Let me think about it, ladies and gentlemen. I can't make that decision right now.
Okay, Dr. Mac.
I have to sleep on it. I'll have a glass of my famous wine.
Drink 2 glasses, Dr. Mac. Drink 2 glasses.
I haven't touched, well, it's almost 6 months old. I haven't touched it yet.
Dr. Mac?
Yes.
There is a concern as it relates to the library for persons who use the library. The library will be closed the 20th and will be reopened on the 5th of January.
You have EBSCO, Ms. Osborne. EBSCO is online for your yes, Mr. Yes.
I'm not sure if EBSCO has been a bit shaky, so I don't know if they still have access. So I'm not sure. So they'd have to double check.
Oh, okay, but okay. So what it's looking like then that we have to defer to January? Is that what people are saying because of these issues? But the other libraries are in Kingston, the University Library. There's IUC or ICU, whatever it is. But you do need to I don't know, when is the library? It's closing the 20th. When is the 20th? This coming week?
Saturday, Dr. Mark.
My goodness. When is it open? When will the library be reopened?
January 5th.
January. Yeah, but Mr. Nyame, well, Mr. Nyame, we'll have to talk privately about the EBSCO.
Okay.
I don't want to talk on. I think it's best I talk to you privately about that.
Okay.
Students, after the presentation, I will comment some more on the assignment. Okay.
Okay.
Let's get the presentation rolling. We have group 3 who will be doing the presentation for this evening, and group 3 knows who they are. And at this time, but before I do that, let me just recap. Did students, before I forget, I want to, what is in my forefront of my mind, the lecture on case conceptualization, was it helpful?
It was, Dr. Mark.
So in other words, it's there for you to, the notes I would have given you, I think it's equivalent to that, except it's child and adolescents, but it goes for adults just the same. If you had that concern. All right, let's group 3. Miss Thompson, since you are the one who is spearheading, could you introduce your group members, please? Go ahead.
Okay, thank you, Dr. Ma.
Yes.
So this group good evening again, everyone. I think Hello Jean just joined us. This group presentation on schizophrenia is done in partial fulfillment of the Child and Adult Psychopathology course offered by the Caribbean Graduate School of Theology. The presentation discusses schizophrenia in general and highlights the disorganized subtype. The presenters are yours truly, Robert Barr, Kido Gaia, and Lataya Daniels Hall. The presentation will cover an introduction, developmental issues, diagnostic criteria, course of the disorder, methods of assessment, etiology of the psychiatric disturbance, differential diagnosis, ethical and cultural applicability to the Jamaican or Caribbean context, role of family factors, and a brief conclusion. Just let me pause here. I'm not seeing the presentation of Robert and Kojo.
You have to click on his name. Click on Robert's name.
Click on whose name?
Robert's face.
Oh, I see. Yes, I see it here.
Can we move on to the scope, the other page?
You have an hour, so go ahead.
Robert, is this the final presentation? I don't think so.
You don't think so?
No, that second page was removed.
Okay.
You should be using the one that, the last one that you received.
The PDF?
Yes.
We're having problems with the PDF.
You want to?
No, this is not the final presentation, guys.
You can start you can just change the PDF.
All right, not a problem, Coach.
Okay.
Dr. Max, sorry about that. I just realized
okay.
it's not
It's
the wrong version that we have up.
So the version the version I got, is it the correct
That is
version?
the final, yes, Dr. Max.
Okay, I just want to make certain because I have it up privately, so I will.
The one that Robert just put up was an earlier version, but that we were trying to load the video on that second page and it didn't work. So that's how I loaded it. We were trying to load a video on the second slide and it didn't work. That's how I know it's an old version.
Okay, but can you, if you have a video, do you have YouTube to take us there?
It's set up already.
Oh, it's set up already. Okay, very good. Very good.
Can we look at the videos while you bring up the PDF, Robert? Or you have it?
Robert, is that the PDF?
No, this is the PDF.
Okay. We
were having challenges every time we opened the PowerPoint, things were shifting around. That's why it had to be PDF.
Okay.
Is that it, Robert?
It is. You guys are seeing it full screen?
Yes.
Yes.
Okay,
Okay.
great.
So, Kojo, can we go to the videos now?
Okay. Can you all click on your YouTube app? Your YouTube icon on the left. I'm gonna start. Are you seeing it? Seeing it?
Yes.
So I'm gonna be starting now.
You started, Kojo?
Yes, I started it. Somebody is playing something else?
Not seeing it.
I hear something. I'm not playing that one. Somebody else is playing it?
Stuffing with like rice and raisins.
What I really like is mukeka, is fish, coconut milk. My family is the most important thing in my life.
Someone is playing another video.
Kojo?
Someone is playing another video. Can you stop that?
I'm not sure who it is.
Okay,
I'm not seeing the video.
Did you click
I'm not
on
seeing the one we should be seeing.
which one we should be seeing? There are two, you know.
The truth about schizophrenia, that's the one.
The third type of symptom that may be present.
Is this the one?
It should be the other one first.
Okay, Marshall just moved something from my playlist. I am gonna have to try and find. Something was removed. It says you removed something from my playlist. So I'm gonna have to put it back. Someone removed it.
Oh my God! Whatever I did, it was not intentional.
Okay, no problem, no problem, no problem. Let me just get it right. I'm gonna play them one at a time. Don't worry. Sometimes these things happen. So which one should go first? Disorganized speech, schizophrenia, or truth about schizophrenia?
Truth about schizophrenia.
Okay, alright. Okay. I hope everybody saw that. Should I run the other video?
Yes, Kojo.
Okay. One moment. Okay.
Thank you, Kojo.
All right.
You put that back the presentation now.
Now everybody click back on your YouTube icon to
And then we have to
remove
click on Robert to
Google.
get the presentation.
Click on Robert again. Yes.
Great. So those two videos were to put our presentation in context. Certainly a lot of myths out there in regards to schizophrenia, and the first video was to clear up some of those myths. The second video focused on one aspect of disorganized schizophrenia, which is what we'll be zooming in on tonight. So we can go on, Robert. So schizophrenia has been a recognized clinical entity for more than a century. The concept of schizophrenia may be traced as far back as the 17th or 18th century, when case accounts of physicians such as Pinel and Haslam implied its existence. The original detailed account of schizophrenia-like conditions is believed to have emerged between the same period when the illness was described as dementia. This condition was later classified by French psychiatrist Benedict Auguste Morel as dementia precox, or precocious dementia. Emil Kraepelin and Eugen Bleuler are distinguished as pioneers of the contemporary notion of schizophrenia. Kraepelin it was who used the term dementia precox to describe diverse psychotic characteristics as one structure. Dementia precox back then included symptoms such as hallucination of auditory or tactile pattern, thought disorders resulting in speech modifications, delusions, and emotional blunting. Symptoms had to be accompanied by clear consciousness, and this means that the client could not have been unconscious while these symptoms were being experienced. The contemporary notion of schizophrenia is credited to Kraepelin, who integrated modern descriptions along with his dementia paranoia into a single disorder, which he believed was of neuroanatomical pathology. Sorry about that. The initial characteristics of this disorder encompassed early onset, poor prognosis, 36 psychiatric symptoms, usually hallucinations in sensory modalities, particularly the hearing, and 19 bodily or physical symptoms. Kraepelin's pioneering work significantly shaped the manner in which schizophrenia is perceived today and later provided a foundation for the classification of disorders in the DSM and the ICD. In 1911, Buehler devised the term schizophrenia, meaning mind that is torn asunder. The term is also believed to mean shattered or fragmented personality. Unlike Kraepelin, Buehler viewed schizophrenia as a psychological construct. His perspectives also influenced the development of the diagnostic hypothesis of schizophrenia and several other neuropsychiatric disorders in the DSM. Buehler distinguished characteristics as primary, meaning related to splitting, and secondary psychological reactions or symptoms. Schizophrenia is a disorder of thinking where a person's ability to recognize reality, his or her emotional responses, thinking processes, judgment, and ability to communicate deteriorates so much that his or her functioning is seriously impaired. Symptoms such as hallucinations and delusions are common. And this is a definition of schizophrenia by Warner, as cited in Birchwood and Jackson. Another definition says that schizophrenia is an extremely unusual mental experiences, including firmly held storage beliefs, which are delusions, and odd perceptual experiences, hallucinations, or they display bizarre behavior patterns characterized by storage body movements and odd facial expressions, use language that is impossible to understand, or groom and clothe themselves in unusual ways. They may have very little emotional feeling or expression, and this is, of course, the flat effect that was referred to earlier. Zooming in on disorganized schizophrenia, this subtype of schizophrenia includes disorganized delusions, stirring hallucinations, unsuitable effect, and people with disorganized schizophrenia subtype typically experience intense social impairment. They may display behavior that is considered silly, giddy, and nonsensical, and their appearance and personal hygiene may be noticeably unkept, and they also experience problems controlling their bladder. Schizophrenia appears more prevalent in urban and technologically advanced countries, such as North American countries, rather than developing countries. Lifetime prevalence rates were estimated as 1% of the general population, and rates in the United States were ranged between 1.1 to 4.7% of 1,000 persons. Schizophrenia is arguably one of the most harmful psychiatric disorders. It results in acute impact on just about every sphere of an individual's life, and this includes economic, their social, every area of their lives. It's regarded as the worst disorder developmentally because it stymies the general developmental potential of persons at most stages of life. Individuals with the disorder typically have relatively enduring challenges with memory, attention, communication, and movements. Onset of schizophrenia is believed to emerge either abruptly or slowly, usually during adulthood, but may also emerge prior to or during adolescence, or even in later life. Onset of the disorder among persons who are below the age of 10 was noted to be extremely uncommon. Prior to 1970, children currently considered autistic received the diagnosis of childhood schizophrenia. The diagnosis of childhood schizophrenia was subsequently removed from the DSM-3 and the ICD-9, making the diagnostic criteria for the disorder applicable across all age groups. So there's no distinction in the diagnosis now whether the person is a child or an adult or an adolescent. Moving on to the developmental issues, findings from studies indicate child and adolescent onset of schizophrenia is associated with significant developmental delays in the areas of language, reading, bladder control, motor development, and sociability. The general population birth cohort and genetic high-risk studies suggests early motor, language, cognitive, emotional, and socio-behavioral developmental maladjustments in childhood may be a pre-existing condition for schizophrenia later in life. Persons with at least one schizophrenic parent were found to be at least 10 to 12 times more predisposed to developing schizophrenia than persons who did not have such parents. In terms of the effects that are caused by schizophrenia between childhood and adolescence, for early childhood, there's gross and fine, there are defects in gross and fine skills development. Early to middle childhood, defects in information processing. Childhood to adolescence, defects in cognitive and neuropsychological development. And in adolescence, behavioral and social adjustments. Research by Almeida et al., as cited in Murray, posited that onset of schizophrenia in later life is related to impairment in a range of tasks. Onsets of schizophrenia, for example, during early adulthood, is believed to be particularly challenging, since this is the developmental period when individuals are trying to establish themselves in the world and become stable and self-efficient and independent identities. The disorder impedes young adults, for example, from pursuing higher education, starting a career, obtaining their own home, and engaging in complex relationships. Young adults who have schizophrenia, rather than pursuing those dreams, are usually forced to either deal with the disorder or remain withdrawn from community. Moreover, adults with schizophrenia generally have less children. They regularly become divorced or separated from their spouses. They experience difficulties with intimacy and are more inclined to become celibate. Disorganized schizophrenia is considered the most chronic subtype of the schizophrenia subtypes. Individuals with this subtype frequently experience decreased levels of social and occupational functioning, which over time results in very poor prognosis. Disorganized schizophrenia results in disintegration of personality and withdrawal. Speech may be incoherent, as we saw in the video. Behavior is uninhibited, along with a lack of attention to personal hygiene and grooming. Onset of disorganized schizophrenia is believed to occur between late adolescence to early adulthood. Moving on to the diagnostic criteria now, the DSM-5 chronicles the diagnostic criteria of schizophrenia as 2 or more of the following, each present for a significant portion of time during a 1-month period, or less if successfully treated. At least one of these must be 1, item 1, 2, or 3. Delusions, hallucinations, disorganized speech, example, frequent derailment or incoherence, grossly disorganized or catatonic behavior, negative symptoms. Criteria B assesses impact of the disorder on an individual's level of functioning in major areas of life. Criteria C looks at continuous signs of the disturbance and how they persist and whether they persist for at least 6 months. Criteria D rules out diagnosis if schizoaffective disorder, depressive or bipolar disorder, major depressive or manic episodes are present. Criteria E rules out diagnosis when symptoms are attributable to physiological effects such as substance abuse or another medical condition. Criteria E assesses for childhood onset of an autism spectrum or communication disorder along with symptoms of schizophrenia. The diagnostic criteria also includes 3 specifiers for first or multiple episodes, presence of catatonia, and current severity of symptoms. Unlike the DSM-5, the DSM-4 TR outlines diagnostic criteria for schizophrenia separately from the diagnostic criteria for schizophrenia subtypes. The diagnostic criteria for the disorganized type states a type of schizophrenia in which the following criteria are met. All of the following should be prominent: disorganized speech, as we saw in the video, disorganized behavior, flat or inappropriate effect. The criteria are met for criteria B, states that the criteria are not met for catatonic type, which is another subtype of schizophrenia. We'll now go on to course of the disorder, and Robert will take us on from here.
Thank you so much, Vanessa. For the course of the disorder, the DSM-4-TR illustrates the fact that there has to be delusion in relation to this person and the course of disorder. There has to be hallucination, speech has to be disorganized, and gross disorganized or catatonic behavior. The individual must be also demonstrating a very flat or aloof lack of motivation in relation to how they conduct themselves. As mentioned earlier, the childhood disorder, the onset, is normally over a period or near normal development. The predominant state has been described in which social impairment, atypical interest, and belief occurs, which could be confused with a social diset seen as autism spectrum disorder. So one has to be careful in relation to how you're going to look at the course of disorder, because it can have comorbid in relation to autism spectrum disorder. Hallucination and delusion are defining features of schizophrenia, but not features of autism spectrum disorder. However, clinicians must take into account the potential for individuals with autism spectrum disorder to be concrete in their interpretation of questioning regarding features of schizophrenia. For example, does the person hear voices, or do they hear it on radio? There's a wide range of symptoms occurring within the course of schizophrenia. Some people have psychotic episode of illness lasting for weeks or months with full remission of these symptoms between each episodes, while others are fluctuating courses in which symptoms are continuous but rise and fall in intensity. Others have relatively little variation in these symptoms of their illness over time. It continues. At one end of the spectrum, the person has a single psychotic episode of schizophrenia followed by a complete recovery. So on two spectrums, one will continue and one can recover over a particular period of time. At the other end of the spectrum, the course in which the illness never abates, hence it continues and increases. The disorganized type schizophrenia, as mentioned before, is disorganized speech, behavior, flat, inappropriate emotion. These three has to be present in relation to the course of disorder over a particular period of time. This form of schizophrenia is typically associated with early onset between the ages of 15 and 25. It is thought to have a poor prognosis, because of the rapid development of the negative symptoms and the decline in social functioning. Disorganized schizophrenia is one of several subtypes of schizophrenia. A chronic long-term mental illness is thought to be the extreme expression of disorganization symptoms that has been hypothesized to be the features of three-factor models of schizophrenia symptoms. The other factors being delusions, hallucination, reality distortion, psychomotor poverty, poor speech, lack of spontaneous movement, and of course, blunting of emotions. Typically, persons with disorganized schizophrenia experience difficulty in performing daily routine tasks, incoherent, illogical thoughts and/or behaviors, easy agitation, purposeless behavior, so they just do things just because it feels good, difficulty in communicating with others, laughing inappropriately for no apparent reason, preoccupation with their own thoughts or perceptions. Methods of assessment. Doctors may ask for a diagnostic test to be done or an examination, which will include a physical examination of the individual, a complete blood count, an MRI, or a CAT scan, a CT scan, an EEG, echo, that word there, and a psychological evaluation. The methods of assessment for children. One, you can do a clinical interview. The name and measure is a schedule for affective disorder and schizophrenia for school-age youth. Who completes it? The client, the clinician with the youth or parent. And this is generated, the data is the diagnosis. Clinician, again, will complete the structured clinical interview with the clinician and the child or parent. The symptom rating scale, the scale of assessment for positive symptoms, the clinician with the child that is suffering from schizophrenia or is suspected to have schizophrenia. The scale of assessment for the negative symptoms, the clinician and the person suffering from the schizophrenic symptoms is. The symptom scale, once again, positive and negative symptom scale, the clinician and the youth. The behavior checklist, the youth self-report, the youth completes that, and of course an assessment is done with the results. And the child behavior checklist, the parent would normally fill that out. And all of those are collated, and then a proper assessment is done of the individual. More assessment for adults. The schizophrenic test and early prognosis test can also be done. The MMPI-2 is another one that we can use to assess, and the special IQ test for schizophrenia. These can be used both for adults and also adolescents. Thank you so much. We move on to the etiology, and Latea will take up from here. Is it Latea? No, Kido will take up from here.
Thank you, Mr. Barr. Good evening, everyone. Several factors posited as contributing factors to the development of schizophrenia. However, the etiology and pathogenesis of schizophrenia is inconclusive, meaning that there is no one factor that caused the disease. This is because some factors mirror other disorders, as well as some factors do not define all schizophrenic patients. Nonetheless, we will explore these factors, integrate our own opinions, and formulate conclusions. These factors, according to Dr. Colin Ross, are genetics, are predominantly genetics and chemical imbalance. Other elements include being burnt out and unmotivated. Biological factors. Hereditary, according to Walker et al., citing Gottsman, mentioned that one of the most well-established findings in schizophrenia research is that vulnerability to the illness can be inherited. Behavioral genetic studies utilizing twin adoption and family history methods have all yielded evidence that the risk of schizophrenia is elevated in individuals who have a biological relative with the disorder. The closer the level of genetics relatedness, the greater the likelihood the relative will also suffer from schizophrenia. Walker notes that when this is compared to persons who were adopted if their biological relatives had no diagnosis of schizophrenia, the offspring was less likely to get it. Recent findings from an adoption study indicate that genetic influences often act in concert with environmental factors. Tinnari et al. Conducted an adoption study in Finland and found that the rate of psychosis and other severe disorders was significantly higher than the matched control adoptees. However, genetic vulnerability was mainly expressed in association with disruptive adoptive environments, and an elevated rate of schizophrenia was not detected in adoptees reared in a healthy family environment. These findings are consistent with the prevailing diathesis stress models of etiology. Taken together, the findings from behavioral genetic studies of schizophrenia lead to the conclusion that the disorder involves multiple genes rather than a single gene. Researchers seem to agree that the genetic contribution may be as a result of mutation. Carlson in Physiology of Behavior said that increased incidence of schizophrenia is caused by mutations in the spermatocytes, the cells that produce sperms. These cells divide every 16 days after puberty, which increases the likelihood of duplicating an error in DNA replication and contributes to an accumulation of mutation. Another factor is the pharmacology, which is the biochemical disorder. Brain circuit activity is driven by neurotransmitters. Initial neurotransmitter theories focus on epinephrine and norepinephrine. Subsequent approaches have hypothesized that serotonin, glutamate, and/or GABA abnormalities are present in schizophrenia patients, but compared to other neurotransmitters, dopamine has played a more enduring role in theories about the biochemical basis of schizophrenia. Dopamine is widely distributed in the brain and is one of the neurotransmitters that enables communication in the circuits that link subcortical and with cortical brain regions. Now, there are many factors, and we'll not be able to go through all of them. Let us continue. It was evidently discovered that antipsychotic drugs have their effect by blocking dopamine receptors, especially the D2 subtype that is prevalent in subcortical regions of the brain. The new antipsychotic drugs are atypical antipsychotics, have the advantage of causing fewer motor side effects. Nonetheless, they also act on the dopamine system by blocking various subtypes of dopamine receptors. Alteration in the dopaminergic reward system, predominantly the striatum, constitute core characteristics of schizophrenia. He goes on to say a reduced functional connectivity between left striatum and temoro-occipital areas, precuneus and insula, could be detected in the schizophrenia group. The positive correlation between gray matter volume and functional connectivity of the left striatum yielded significant results in a very similar network. Connectivity of the left striatum was negatively correlated with the negative symptoms. Neurological factors, which involves brain abnormalities. Post-mortem studies of the brains of patients have revealed a number of abnormalities in neural density, structure, and interconnections. These include reductions in neuron density and abnormal neural morphology. Cytoarchitecture, dendritic abors and spines, but with no signs of gliosis. The absence of gliosis, which typically develops following a postnatal brain injury, has led to the conclusion that the cellular abnormalities reflect early developmental abnormalities. And we will, in the interest of time, we'll go to the next page, Robert. Right. The hippocampal abnormalities have been demonstrated in schizophrenia. It is, however, unclear if it affects cognition and functioning. And then we go on to the environmental factors, obstetric complications. Events that adversely affect fetal development are now considered to be sufficient on their own to produce vulnerability in schizophrenia. There is extensive evidence that obstetrical complications have an adverse impact on the development of fetal brain, and numerous studies have shown that schizophrenia patients are more likely to have a history of OCS. Included among these are pregnancy problems such as toxemia and preeclampsia, as well as labor and delivery complications. Maternal complications, which includes infections. Researchers have found that the risk rate of schizophrenia is elevated for individuals born shortly after a flu epidemic or after being prenatally exposed to rubella. The findings from research on viral infection are consistent with reports on the season of birth effect in schizophrenia. Several studies have found that a disproportionate number of schizophrenic patients are born during the winter months. We'll go on to postnatal brain injury. There is a substantial body of literature showing that individuals who sustain head injury are at heightened risk for a variety of psychiatric disorders, including schizophrenia. And then we move on to environmental stressors. It is well established that stress exposure impacts brain function. This effect is partially mediated by activation of the hypothalamic pituitary adrenal axis, one of the chief neural systems involved in the biological response to stress. Activation of the APA axis results in a cascade of neurohormonal events that culminates in the release of cortisol from the adrenal gland. Cortisol has pervasive effects on brain function, and it can alter the activity of neurotransmitter systems. When stress hormones are chronically elevated, structural brain changes can occur, such as reductions in hippocampal volume. Elevation in cortisol are linked with more severe symptoms and cognitive deficits in schizophrenia. Have reviewed evidence of HPA dysregulation in schizophrenia. In their neural diaphysis stress model, they describe how heightened cortisol release has the potential to exacerbate schizophrenia symptoms by augmenting dopamine activity. The chronic stress inherent in suffering from a psychotic illness may also contribute to the degenerative brain changes. It is important to note that each one of these factors is not sufficient to bring about health or mental illness. but the interaction between them determines the course of one's development. Differential diagnosis. Kraepelin, cited in Strakowski, proposed a separation of dementia precox, which is schizophrenia, from manic depressive insanity, which is bipolar, based on the differences in the course. They share similar symptoms. They can be indistinguishable. For example, depression and anxiety are associated with both bipolar and schizophrenia. Psychosis, which is used as one of the major diagnostic criteria in schizophrenia, is also common in bipolar disorder, affecting up to 80% of manic patients. Similarly, depression, which is a major feature of bipolar, affects up to 80% of people with schizophrenia. Also, depressed patients with bipolar disease display broad patterns of cognitive impairments that are somewhat similar to those seen in schizophrenia. The DSM-4TR differentiates schizophrenia from psychotic disorder due to general medical condition, delirium, or dementia. It also differentiates schizophrenia from substance-induced psychotic disorder, substance-induced delirium, substance-induced persistent dementia, mood disorder with psychotic features, and schizoaffective disorder, delusional disorder, pervasive developmental disorders, communication disorder, and attention deficit hyperactive disorder. We now move on to the ethical, cultural applicability to the Jamaican or Caribbean context, and this will be done by Latia.
Good evening, colleagues, and Dr. Mack. Are you hearing me? Good evening.
Good evening.
Good evening.
That's the confirmation. All right, I will be looking at the ethical, cultural applicability to the Jamaican or the Caribbean context. Now, the world is recognizing that schizophrenia is one of the most prevalent mental disorders that people are struggling with. And the Caribbean is no exception. It is believed that there's actually 26 million persons, according to the World Health Organization, who are living and suffering from schizophrenia. Now, I may ask a question just to get us talking just a little bit. How many of us were aware of what schizophrenia is before exposure to this program? May I just get feedback from just two persons? As a Jamaican, what do we know about schizophrenia prior to the exposure?
Or a Guyanese.
And a Guyanese. Sorry, Vanessa. I would love to hear from two persons.
Well, I'm certainly aware of the disorder. Most persons that are admitted to our mental institution at home are somehow diagnosed with schizophrenia. Prior to this presentation, I knew it involved odd speech and odd behavior. That's essentially what I knew.
Okay.
Yeah, and then most persons who suffered from the disorder generally isolate themselves or withdraw themselves from society.
Okay. One of the Jamaicans?
Well, okay. I don't want to be biased, but I knew about schizophrenia. What I never knew about is that you had a disorganized subtype of schizophrenia. So I have learned a lot in relation to just doing the research and being in the classes.
Right. All right. Thank you, guys. The reason I asked this question is because of the fact that while schizophrenia is so prevalent in our society, not many of us as Jamaicans are truly aware of what this is. Now, I did a vox pop, and unfortunately the video was not able to play. With some people I came across as to some understanding as to what this is. And some of it was startling because there were some people who could have said that it's a mental disorder. There were others who just thought it was just the main sign of madness. And the main sign, it means it speaks to a lack of disorientation in speech and mental processes, while some just didn't have any idea as to what schizophrenia is. Now, as you're seeing on the PowerPoint presentation, the earliest epidemiological report on schizophrenia, please go back, in the Caribbean was from Jamaica. So the first time that they actually did this type of report came out of Jamaica in the 1970s. That's what should be there, which indicated that the annual population incidences rate was from 150 persons per 100,000 persons. Now, Burke and Hickling confirmed this finding and reported an annual incidence rate of 136 per 100,000. So these were based on mental hospital admissions rate, and it's likely that these studies failed to assess the total number of admissions for the island. So these were coming out of the reports that were given to hospitals. Now, another study of psychiatric admission to private and public hospitals across Jamaica reported that the incident rate of schizophrenia had fallen from 69 per 100,000 in the 1970s to 35 per 100,000 in the 1990s. So we see there 20 years, in between 20 years, there was a decline. Now, they're arguing that this decline is attributed to findings that have been improved as a result of outpatient treatment and outcomes provided by community psychiatric system. So the more outpatient psychiatric system that were introduced in our country, is the less report they had received in regards to schizophrenia. This had been introduced in the island in the early 1970s. Thank you, Robert. It is argued that the symptoms of schizophrenia is often confused with features of demon possession, and we have been discussing this as it relates to mental disorder a great deal. Now, why would we really confuse schizophrenia with demon possession? It's the whole idea of hearing voices in your head, disorientation in speech, also the fact that persons who are schizophrenia also is evident when we have persons trying to kill themselves. Now, our society, our country, as we know, the cultural factors that will influence this, of course, is not just Christianity. So many persons may want to think, oh, we are a strongly Christian country, so this is why we might want to think demon possession is related to this. No, in my research, I actually found that this possession of demon, as it relates to schizophrenia, is not only linked to Christianity, it's linked also to the practice of obeah. Now, you may differ, but I've come to find that as it relates to obeah and the spirit possession, I don't know how many of you are familiar with the term of casting a spirit on you because you have a conflict with your neighbor or a conflict with somebody and then put dopey on you. Yeah? Now, if you're familiar with this term, the things dopey being on you, interestingly, is identical to some of the symptoms of schizophrenia. So it's the signs of knowing that you are possessed by a demon, as if for Christianity, or possessed by a dopey, as it relates to obeah, manifests itself in you being unable to speak, manifests itself in you being unable to focus, to think. You become suicidal and totally unrelatable. So this is something that is typically confused with schizophrenia in our society. Now, interestingly, many of the diagnosed cases of schizophrenia reach the clinician through referral from medical physician who reported these persons enter the emergency room after being hurt. So the clinician, in synopsis of what I'm saying here, the clinicians find out about cases of schizophrenia after they have gone through the medical physician. So our society is one in which people will only seek help when they are in a crisis situation, it's a crisis and their family members or co-workers urge them to get care. So we may not typically report the cases unless some crisis is involved. This is why they enter through the medical physician or through the emergency room. Persons with schizophrenia may end up getting hurt, they're abused, and that's how they end up in the emergency room. They try to hurt themselves, they end up in the emergency room. The medical physician therefore refer them to a clinician after observing these. Please continue, Robert. Now, I wanted to show you guys this table which demonstrates the psychiatric diagnosis made on patients through referral at a medical institution in Jamaica. You will observe that at the top of it, depressive disorder, adjustment disorder, are the highest rate of referral cases. Now, these are according, as you can see, to a 2006, 2007, so it's some time ago. Notice that schizophrenia referral is at 14 in terms of the patients who were diagnosed as being schizophrenic through referral from a medical doctor. So we see that a lot of them had indeed passed through the medical doctor in order for them to reach their situation, to reach the clinician. Robert? Now, schizophrenia is a cause for national concern here in Jamaica, according to Dr. Fenton Ferguson, our Minister of Health. Now, in addressing the nation on National Mental Health Day, which was actually the 10th of October 2014, he expressed that the theme actually was living with schizophrenia. So the world have been zooming in on this whole issue of schizophrenia. Now we noted that the impact of schizophrenia on the country is an enormous burden. And I was particularly interested by the fact that he used the words enormous burden. However, the exact number of Jamaicans living with this disorder, he said, was unknown. Because again, not a lot of research has been done since the 70s and as we see in the 90s of what really is happening with schizophrenia in our country. He noted that this burden can be alleviated if other government agencies and communities join in an effort to offer improved services and care to those afflicted by the mental condition. So the main burden for him is that, according to the Gleaner report, is that we do not have the support of members of the communities. Family members are not coming in. It's dependent greatly on the government to take care of persons who are living with mental condition as a whole. He believed that we need to raise awareness about it in a bid to reduce stigma and discrimination. So some of the responses, of course, we got from the Vox Pop demonstrate a high level of discrimination because of lack of awareness of what this disease is. Also, it's one of the reasons why these persons end up in the emergency room. We don't understand their situation, we don't understand their condition. As a result, they become abused. Yes? As they offend others, we don't know what they're going through. We abuse them to the point of hurting them seriously. They end up in the emergency room. So we can agree with Dr. Fenton. Now, in addressing the needs of a person living with schizophrenia, he made a very important point, and he said that we need to take a whole government, whole society approach because it's everybody's business. It's not just the persons and the family members of persons who are suffering from schizophrenia. It's a everybody business. He pointed out that care for schizophrenics, is labeling there, I've learned better, is offered via inpatient hospital and outpatient settings in hospitals or clinics. So the majority of the treatments are at hospitals or major hospitals, including Bellevue. There's also a good program, I understand, at the Cornell Regional Hospital in Montego Bay that happens to have a high number of